Hey doctors. So today I'm going to discuss about another Mrcp basis consultation station, and this case has appeared in the consultation station, so I thought maybe it's a good idea to discuss this. So this is a case actually of hepatomegaly with ascites. Okay, let's move on to a case. This is a case scenario here. Mr. Smith, 65-year-old gentleman, who presents with a history of progressive abdominal distension and discomfort over the past few weeks. He also reports increasing fatigue and a sensation of fullness after eating. So here in this case scenario, you have around 4 to 5 minutes to think about it, do some brainstorming and think about all the differential diagnosis. So always look for the buzzwords. So here we have a progressive abdominal distension and some discomfort, and there is some fatigue. So abdominal distension, we have to think about ascites, we have to think about patient is having fatigue. So think about all the causes of the abdominal distension, not limit yourself to the ascites, but it can be some abdominal mass, or it can be just abdominal distension because of ascites. So think about all the differential diagnosis. First of all, we're going to start with the history taking. So once you enter the consultation room, you take the consent from the patient, introduce yourself, something along the lines that my name is Dr. This and I'm one of the doctor working here. Today I'm going to ask you about your complaints, and after that I'm going to do the brief clinical examination and then going to answer any queries. So this is your brief introduction. So in the history taking, obviously whatever is the patient presenting complaint, we're going to inquire about here the complaint is abdominal distension, so we want to know about the duration and progression of abdominal distension, and then at the same time we'll be interested in knowing about any associated symptoms like weight loss, anorexia, jaundice, or lower limb swelling. We want to explore more about the medical history, so explore any pre-existing medical conditions, particularly liver disease, chronic hepatitis, alcoholism, or heart failure. Then in the history taking, we want to know about the medication history. So ask about the current medications, including diuretics or anticoagulants. These may contribute to fluid accumulation. Social history is important. We assess the alcohol consumption. Ask about the smoking history and any recent travel or exposure to infectious disease. Travel history is also sometimes important because we're thinking about causes like hepatitis, or particularly thinking about hepatitis A, and also thinking about hepatitis B or C, depending on the risk of the exposure. Family history, we want to inquire about a family history of the liver disease, about cancer or other relevant conditions. So I put some points briefly here about the history taking. So try to, in your examination, try to be systematic. And if you have your own plan, just follow the plan of the history taking. Then we go and we'll take the consent from the patient after we've taken the history, and we'll perform the examination. So first of all, the general physical examination is important because you are thinking about ascites and thinking about maybe the patient has a chronic liver disease. So in the general physical examination, first of all, we'll look for any yellow discoloration of the skin or sclera, which is indicated of jaundice. We also want to look for any signs of the chronic liver disease like spider angiomas. And here I have, you can see the picture here, and these are characterized by central arterioles. These are central arterioles, and then we have a radiating capillaries here. So it resembles a spider body with legs, and these are commonly seen in patients with cirrhosis, and the cause is elevated estrogen levels and portosystemic shunting. When you are doing the general physical examination, look at the hands for any palmar erythema and note the redness of the palms, particularly in the thenar and hypothenar eminence. And here you can see some redness here in this picture. And in the hand also look for any clubbing. So examine the nail beds for clubbing, which may occur in chronic liver disease. This occurs because of chronic hypoxemia and impaired peripheral circulation. So here you can see clubbing here. Gynecomastia, well, assess for the presence of gynecomastia, and these are also associated with liver cirrhosis due to hormonal balance and impaired estrogen metabolism. Okay, so once you have done the general physical examination, you are going to move on to the abdominal examination. So going to palpate for any hepatomegaly, any tenderness, and the presence of shifting dullness, which is suggestive of ascites. And we also assess for abdominal veins and signs of fluid overload like peripheral edema or any stigmata of chronic liver disease like spiroangiomas and gynecomastia. We have discussed it earlier. Now remember, this is a consultation station. So our examination will not be limited to just the abdominal examination. We want to move and do the cardiovascular examination as well. Especially we want to evaluate for any signs of heart failure. So just look at the JVP, listen to the lungs look for any crackles on lung auscultation and pedal edema. We also want to do the respiratory examination in this case. We listen for any signs of pleural effusion, which may accompany ascites in patients with cirrhosis or heart failure. And we offer the digital rectal examination to assess for any signs of rectal bleeding or masses suggestive of gastrointestinal malignancy. So in examination, remember this is a consultation station, so we have to think broad, so do all the examination. Another important point which I would like to highlight is, once you are doing the examination, keep on giving the running commentary also. Take the consent from the patient repeatedly, there is no harm in it. Like you can tell the patient, like if you're doing the abdominal examination, I would like to look at your tummy now. I'm going to palpate for the liver now. I'm going to palpate for your spleen now. You can say that, there is no problem in that one. So at each step, just explain to the patient and also look towards the patient to see whether you're not causing any discomfort to the patient while you're doing the examination. So coming to the differential diagnosis, in this case, we will thinking about the cirrhosis, which is commonly associated with hepatomegaly, ascites, and dilated abdominal veins due to portal hypertension. In the differential diagnosis, we will also be thinking about a heart failure because it can present with signs of fluid overload, including peripheral edema and elevated JVP and pleural effusion. Malignancy is also in the differential diagnosis because liver or abdominal malignancies may present with hepatomegaly, ascites, and signs of weight loss or anorexia. And infectious causes, ascites may occur secondary to infections like tuberculosis or spontaneous bacterial peritonitis, particularly in patients with underlying liver disease. So these are our differential diagnosis in this case. And this is a very common question in your viva. The examiner may ask you what is your differential diagnosis. Coming to the investigations approach, we want to do the liver function test to assess for any evidence of hepatocellular injury, for cholestasis or synthetic dysfunction. So we want to do the enzymes as well as PT and INR. Imaging, we will like to perform an abdominal ultrasound to evaluate for hepatomegaly, for any liver nodules and presence of ascites. We can consider CT or MRI for further characterization. If the patient has ascites, it's important to mention about the ascitic fluid analysis. So we're going to perform parasynthesis to analyze ascitic fluid for cell count, protein, albumin, cytology and culture. Serological markers, we want to test for any viral hepatitis. Markers, also autoimmune antibodies like ANA, anti-smooth muscle antibodies, alpha fetoprotein to screen for liver disease and malignancy. So we're thinking about other causes as well, like primary biliary cirrhosis and hemochromatosis as well. Coming to the management, obviously we want to treat the underlying cause. So whatever is the cause, whether it is a cirrhosis or heart failure or malignancy, and we're going to do some dietary modifications, low salt diet and fluid restriction to manage the ascites and fluid overload. Diuretic therapies, we will initiate diuretics like spironolactone or furosemide to promote diuresis and reduce fluid accumulation. Parasynthesis, perform the therapeutic parasynthesis for symptomatic relief of tense ascites, and also to obtain the ascitic fluid for analysis. And if there's any complications, we need to manage the complications like spontaneous bacterial peritonitis, hepatorenal syndrome or hepatic encephalopathy. So all these are complications. So if the patient has complication, going to treat the complications as well. Let's move on to the case presentation. So once you have done your history and your examination, and if the patient has any queries, you have to answer that queries as well, because this is a consultation station. So how are you going to present this case? So this is one of the way that how you can present. Today I will be presenting a case of a 65-year-old gentleman, Mr. Smith, who presents with hepatomegaly and ascites. Going to then give briefly about the history. Mr. Smith's history reveals progressive abdominal distension and discomfort over the past few weeks, along with increasing fatigue. On examination, he demonstrated hepatomegaly, shifting dullness, and dilated abdominal veins suggestive of ascites. Differential diagnosis includes cirrhosis, heart failure, malignancy, and infectious causes. So investigations will include liver function tests, abdominal ultrasound, and ascitic fluid analysis to determine the underlying etiology of his symptoms. And the management will focus on treating the underlying cause, dietary modifications, diuretic therapy, and therapeutic parasynthesis as needed. So this is how you're going to give your presentation. I put some of the questions which are commonly asked in this case. This is a very common question which they ask. The examiner may ask, what are the common causes of ascites? So remember, the common causes of ascites include cirrhosis, heart failure, malignancies, and infections such as tuberculosis or spontaneous bacterial peritonitis. This is also a very favorite question. How would you differentiate between transitive and exudative ascites? So one of the answer is here. Transitive ascites is typically caused by systemic conditions such as liver cirrhosis or heart failure, while exudative ascites is often associated with local peritoneal inflammation due to malignancy, infection or parasynthesis. And remember this one as well. This is ascitic serum ascites albumin gradient ratio, and it is usually greater than or equal to 11.1, then it suggests a transudate. So typically associated with portal hypertension, while if the ratio is less than 1.1, then it indicates an exudate, which is suggestive of inflammation or local pathology. Another question which may be asked, what are the complications associated with TAN ascites? So complications of TAN ascites may include spontaneous bacterial peritonitis, hepatorenal syndrome and abdominal compartment syndrome, and these can lead to significant morbidity and mortality if not promptly managed. Describe the management approach for the spontaneous bacterial peritonitis. So management involves empirical antibiotic therapy with third generation cephalosporin or fluoroquinolones along with albumin infusion in selected patients to reduce the risk of renal impairment and improve outcome. And how we will assess the response to diuretic therapy. So it is assessed by monitoring the body weight, urinary output, serum electrolytes and renal function tests. So these are some of the questions which may be asked in this case. So hopefully this presentation will help you, and I'll see you in my next presentation.